Mark Emberton is my name. I live and work in London. I'm a clinician scientist, so I have duties looking after patients, but half my time I spend doing research. So the patients I look after at UCLH, NHS Trust, and the research I do at UCL, which is the university, and we work in partnership. So I made the decision to get Sonoblate over 20 years ago now. So it was about 2003, I think, at an AUA where I saw the technology for the first time. At that point, I'd been doing radical prostatectomy for a while, and I was looking for a way to treat patients less invasively. There were two systems. There was a French system and there was the Sonoblate system, and I liked the attributes of the Sonoblate system. And then soon after that, we managed to get a system to start using in the UK. Obviously, this was in a pre-MRI era, so we were starting to treat patients at the whole gland level, and we were very satisfied with the way we did that. And then once MRI came about, we switched to focal therapy, which was the beginning of the story that we're going to talk about. So quality of life is hugely important for men. So I'm obviously seeing men, and they seek me out, who are very keen to preserve continence and to preserve sexual function. And obviously they place high utility on that. So I don't see the men that want to, above all, treat the prostate cancer with a belt and braces approach. They tend to say yes to surgery or to radiotherapy initially. So the kind of men that I'm seeing, and I think this cohort is increasing in size, are men that want their cancer treated, but also want to be like they were before. And the beauty about focal therapy is that you can achieve that in the vast majority of patients. As I said earlier, we started in about 2004, and then for a couple of years did whole gland treatments, so to replace radical prostatectomy or surgery. And then soon we became aware, largely because of imaging and the change in biopsy techniques, that we could identify localized disease somewhere in the prostate. And of course, HIFU gave the opportunity for us to treat the prostate in a selective manner. And then in about 2008, we started recruiting patients into a trial that demonstrated that we could treat patients in a focal manner. That was a hemiablation study, and preserve their continence and preserve their sexual function. And that was published in 2010 in JUROL. So obviously it's a huge shock. Men are well, they feel well, and suddenly they have a PSA test which is abnormal, and then it's a real kind of number of things happen. They have an MRI hopefully, and then they might have a biopsy. That can all happen in a few weeks, and it's a huge amount to take in. So the first thing I try and say is actually there's no rush in making a decision, and then we spend that time making sure we understand everything we can about the cancer. Is the MRI of high quality? Do we know where the cancer is? Does everything align? In other words, are the biopsy results concordant with the MRI, and these days with the PSMA PET, and maybe these days also with ultrasound? And if that's the case, then we explore the possibility of focal treatment. Men are hugely relieved when I tell them that they are eligible for focal treatment, because they think that they're standing on a precipice, about to undergo surgery and about to have their quality of life diminished. The most disappointed people I see are the people that come to me to see if they're eligible for focal therapy, and after the work I say that you're not, because there's disease there, and you might have some more disease coming up there, and you're going to be better treated at the whole gland level. And they're very troubled by this, and some of the men actually then refuse to undergo treatment. So it's very difficult, but it's very important for people to understand that not everybody is eligible for focal therapy. Some people are better served with maybe active surveillance or no treatment, observation. Some people might benefit from modern radiotherapy, which many times can be done without hormones these days. Radiotherapy has improved a lot, and obviously some men will need surgery. But the important thing is that men are risk stratified appropriately, and then are given the options that are very reasonable for that individual. I think if you're worried about your prostate, it's about getting access to MRI, right? And I know in some jurisdictions that's harder to do than in others, But actually, all the tests that we do, all the kind of PSAs and the other biomarkers that can be done are really to see if you need an MRI. And so what we've done, we've lowered the threshold for referring people for MRI, and actually we've made the outcome of the MRI hugely beneficial for patients. So not that long ago, everybody at risk had a biopsy. Today, if you have a normal MRI, you're reassured, discharged back to the GP. We set a threshold of PSA on which they can return and have another MRI. If the MRI looks, just slightly abnormal, what we call indeterminate, we can watch it. We can just repeat the MRI in a year. If there's an abnormality on the MRI, there's no need to dive in and do a biopsy. We can monitor that lesion over time. We can. These are all relatively recent opportunities, whereas before everybody had a biopsy. Now we can use MRI to kind of do one of those three things. It's very straightforward. So if you go to your GP and your PSA is marginally elevated, or you have a family history, or indeed you're just anxious about prostate cancer, you will invariably be referred to secondary care, and we can do an MRI on everybody that's referred to us.
Relatively.
Yeah, I won't see a patient without an MRI beforehand because there's nothing to talk about. HIFU gives men the opportunity to have their prostate cancer treated without a reduction in their quality of life, and that's huge, right? What's sometimes sad is that not all men are given that opportunity, and maybe the surgeon or the radiotherapist that the patient is seeing will not mention focal therapy, or will not even ask the question about whether this patient is eligible for focal therapy, and that patient will not get referred. So often it's stumbling across something in the media, it's speaking to a patient that's had focal therapy, or it's a relative doing a search on the internet that will say, well, have you thought about HIFU or some other form of focal therapy? And they're the patients we tend to see. But that can be very dependent on luck and chance. It's improving, and through websites and awareness, an increasing number of patients are aware that HIFU exists, for example, but it's still not everybody. Well, focal therapy, and I use HIFU in the majority of those patients, allows me to treat the cancer and preserve genitourinary function. By that I mean that the patients will not be incontinent. I tell patients they will not be incontinent as a result of that. And the majority of men who have good erectile function before treatment will keep erections. And the majority of those men will tell me that the erections are very much the same as they were before treatment. And you see a patient 3 months after, their PSAs come down, you know you've got the cancer from the early post-treatment MRI, and then you ask them how they are, and they say they're continent, they're peeing a bit better than they were before. Patients do on average improve. And they tell me that their erections are pretty much the same as they were before. The one thing that does change is the volume of ejaculate, and the nature of the ejaculate can become more kind of water-like, more liquidy. So hemiablation is when we treat half the prostate, either left or the right-hand side of the prostate. Sometimes an individual might have 2 or 3 cancers on one side of the prostate, and you can encompass all of them by treating that lobe. The treatment is limited to men with relatively small prostates, so we can reach the true extent of the lobe. It's an anatomical treatment, so the treatment boundaries are defined by the anatomy, not by the cancer. So it's slightly different to what we might call standard focal therapy, which is where you identify the cancer, you know where it is, and then you treat the cancer with a margin around it. And so then the treatment is defined by the cancer and not by the prostate. But the hemiablation is how we started, and the hemiablation is a very, very good way of treating. And the results are very, very similar, apart from ejaculatory function, to just treating the cancer plus a margin. So this is an interesting question. Most of the guidelines would suggest that focal therapy should be done in men to low of moderate risk. I think if you're treating men at higher risk, you have to be very careful, but these days you can be. We've got exceptional imaging in the form of MRI and these days PSMA PET, and PSMA PET then caps the risk. So if the PSMA shows no spread of cancer beyond the prostate, you know that you're dealing with localized disease to the best of our ability to define it. And also the PET helps localize the disease. And in high-grade disease, the PET scan and the MRI usually overlap 100%. So you've got a very, very clear target. So if you're going to treat high-risk disease, in other words, high-grade disease, you want to catch it early when the cancer is small. That's not too difficult because high-grade disease lights up. You can see it very, very clearly on MRI. We're finding it very early because you can see it so well. And with PSMA PET, you can cap the risk. So high-grade disease doesn't have the same risk that it used to have. And in very carefully selected patients with appropriate consent, you can treat them. Well, treatment precision is important in all of medicine. I would hate to argue that imprecision is okay. It's not. Precision is at the heart of what we do. In fact, in many talks I've given, I'm saying that a focal therapy program improves everybody. Not just the patients that are being treated, but all the clinicians that are working in that unit benefit because of the exacting requirements that we have in terms of risk stratification. So if the cancer is being removed in its entirety with the prostate or being irradiated, it doesn't matter where the cancer is. It doesn't matter how many cancers are in the prostate. They're all coming out or being treated. With focal therapy, we've got to be sure where the cancer is and sure where it isn't. And that's, imaging, MRI, ultrasound, PSMA PET, very careful biopsies get us there. So precision, we cannot do this without precision. Precision is at the heart of what we do. Big prostates are more challenging for everything, right? There's just more tissue there. The main reason big prostates kind of get in the way is largely as a result of sequelae following focal therapy. So the catheter times can be longer, the requirement for recatheterization can be increased, and then the risk of infection will increase if either of those two things happen. Now, if you can reach the cancer, you can treat it. But it's much more difficult to treat in a big prostate because your anatomical landmarks are outside your window of treatment. So it's very hard to know where you are. Fusion is harder in a big prostate as well. So everything is a little bit more difficult in a large prostate. And when I'm mentoring people about starting a program, I always say start small, right? Start with a 30 cc, 40 cc prostate. You can see the whole prostate on your treatment window. You can constantly remind yourself where you are in terms of key anatomical landmarks, which you can't in a prostate that's the size of a grapefruit. The sound waves just disappear into it. So it's not something you cannot do. It's something that you should wait to do until you've got sufficient experience treating smaller prostates. So some of the most anxious patients are those that have had prostate cancer treated with, say, radiotherapy and then have failed. Right? And they come to you seeking the opportunity to have their cancer treated, cured, to use that term, because the alternative is to go on hormones and chemotherapy, is systemic therapy. These are the only patients that want to have cancer. So somebody whose PSA is rising after radiotherapy, that you evaluate with MRI, PSMA PET, and a targeted biopsy, if you find a cancer, and it's one that you can treat it. If you don't find a cancer, that patient is back in square one. So they have a rising PSA, but nobody knows where it's coming from. So they tend not to get focal treatment, and they're extremely disappointed. So it's a very unusual situation. These salvage patients, as we call them, so patients who've recurred after radiotherapy, are a little bit harder to treat. But focal therapy seems to be very well tolerated, and HIFU works particularly well in these patients. But the side effects are greater, and patients need to be warned about those because the tissue is semi-viable given the amount of radiation that they've had. The rectum is less mobile given the amount of radiation they've had. The urethra is maybe stenosed given the amount of radiation they've had. So everything's a little bit more difficult, but the good news is that we can get the majority of these patients through without increasing the side effects, without diminishing their quality of life, and allowing them not to need to go onto hormones. So it's a very, very satisfying area in which to work. Focal therapy with HIFU or with any form of treatment is a very personalized treatment. Everybody gets a slightly different treatment because every prostate is different and every cancer is different. And the treatment, the whole thing about focal therapy is that it's the cancer that defines the therapy. And so it's completely individualized. Whereas surgery and radiotherapy, you pretty much do the same thing to everybody. You might modify it a little bit, but everybody gets basically the same treatment. And so focal therapy is a very good example of modern, completely personalized, tailored treatment for the individual. Obviously, a patient that's having HIFU, and it's usually focal HIFU, will have had a diagnosis made, will have agreed that they are eligible for it, and then it's a case of finding a date. In that time between finding a date for surgery, it's normally a couple of weeks that we can do it. They'll spend some time with the nurses or nurse specialists to learn a little bit about preoperative preparation and postoperative recovery. They'll also learn about managing the catheter. So the catheter stays in for about 3 days. There's no preparation the patient has to do prior to the treatment, unless they're on, say, anticoagulants, or blood thinning agents, and then they'll be stopped for a couple of days beforehand. And then we give an enema to the patient on the morning of the procedure. So sometimes people will fly in that morning, we'll give them an enema, and then we'll treat them. The treatment is done as a day case procedure. So the patient comes in the morning, goes home in the afternoon. The treatment typically takes between 1 and 2 hours to complete, and the patients go home about 2 to 3 hours after the treatment is completed with the catheter draining clear urine. And the only other thing we tell patients is that for the first half an hour or so when they wake up, they will have a sense that they need to go. They'll have a catheter in, and the prostate will be a bit swollen, and they have this kind of urgent need to empty their bladder. If you warn them about it and reassure them about it, very, very few men need any other form of medication. That always goes away. By the time the patient is discharged, they go home comfortably. We then tell them to go for a walk I treat on a Friday, we tell them to go for a walk on the Saturday, walk on the Sunday, and they come back on the Monday for catheter removal and post-treatment MRI, where we assess the quality of the treatment. That's a luxury that we have. It's not a luxury that everybody has, but that's a very useful way of being able to tell the patient, yes, we have got it all. The week afterwards, they tend to feel a bit tired. They're back to normal activities, back to the gym, back to swimming, whatever they want to do. And so we tell them to kind of keep off work maybe, or light activities. And then the week after that, they're back to doing whatever they want to do.